Hello, everyone. This is Joanne. Welcome to the Training Institute for Dissemination and Implementation Research in Health Pre-Institute webinar. This webinar is being recorded. If you have any objections, please disconnect at this time. Just a few session logistics before we begin. Please note that all participants have been muted for the webinar. At any time during the presentations, you can also submit a question, either content-related or logistics-related, using the chat function at the right of your screen. Please simply type your question into the box, select Joanne as the recipient, and hit submit. All questions will be answered during the Q&A portion of the session at the end. If you don't see your chat enabled, if you go towards the top right, you'll see a little chat icon that will open up the window for you. So during the webinar, we will be providing an overview and rationale for the Training Institute. We will then be jumping into D&I Part 1, Dissemination Science and Designing for Dissemination, and then D&I Part 2, Implementation Science. We will then end the webinar with questions and answers. And if Karen is there, I'm going to now hand over the webinar to her. Karen, are you there?
I am. Can you hear me?
Great. Yes, we can.
Great. Hi, welcome everybody. I'm so delighted to have the opportunity to welcome you to TIDIRH 2015. I'm Karen Emmons, the Vice President of Research at Kaiser Permanente and the Director of the Kaiser Foundation Research Institute, and have been doing work in D&I for many years in my own research program prior to my joining KP a couple years ago. It's been such a wonderful journey to watch dissemination implementation science really develop and now grow to the point that it is in the field. So we're very happy to be sponsoring and hosting TIDIRH this year. You are joining a pretty elite group of scientists. You're the 5th class of the TIDIRH series, and this is a really competitive process to get into TIDIRH. We select the scientists who have the most promise for having an impact on the field of dissemination implementation science. So I know you're all on mute, but I'd like to think there's a collective cheer and clapping for yourselves in the background, because you deserve a lot of congratulations for being accepted into the Institute. This is competitive and something that a lot of people around the country keep an eye on, and we think a very, very important part of our national research effort to really bring more high caliber work into this area. So I'm going to go through just a few logistics slides and talk a little bit about the goal for the Institute. And the primary goal is really to build capacity for this area of science. And we have sort of 3 strategies for doing that. The first is training, and that is to prepare investigators and build and expand a network of investigators working in this area. And then the second aspect of that is to encourage interest at academic and research interests across the country. And that's why NIH used this very wise strategy of rotating the host of TIDIRH. For the last 4 years, it's been at various universities, University of North Carolina, UCSF, WashU, Harvard, and this is the first time that it's being hosted in a health system where we have an active research capacity, but also serve largely as a health system, and in collaboration with the Cancer Research Network, which many of your institutions, I think, are participating in. So we're very pleased about being part of this. The other aspects of building capacity are to provide mechanisms for information sharing and hosting conferences at which we hope many of you will attend, and then creating and letting people know about funding opportunities. The features of TIDIRH are a few that I think are worth noting. The first is this is sort of an in-residence training program. It's going to be held at the Westin in Pasadena, a lovely area to be in, but we certainly don't want you to think about this as a California summer vacation, because it's going to be intense, very focused. This is designed to be very interactive. We work very hard with our presenters to make sure that they have dynamic and interactive presentations, so you're not going to be just in a one-way recipient mode. You're going to be very actively engaged throughout the week. We do build in networking time through breaks and meals. We will have, as part of the sessions together, breakfast and lunch We'll have at least one group dinner, and on several other nights, faculty may be available to go out for casual dinners, or groups may go out for dinners together. So we built this in as having lots of networking time. We see that as a very, very important part of the Institute. The whole idea behind the Institute is that it has a train-the-trainer approach. So we are hoping that when you are done with the Institute, you will be well prepared both in terms of your learning and knowledge and the materials that we provide, including all of the slides and slide notes from the presenters, to be able to go back to your home institutions and do some of this training yourselves, be able to talk to people in your department, in your own research group, and others about specific aspects of this area of work. We think that's a very important part of this. All of the lectures are also archived, so you will be able to refer to those or have those as access points as you do your own training. We try to make this very flexible in terms of very dynamically getting your feedback. So we ask for a daily evaluation of your experience and how we're doing. And the faculty meets at the end of every day and does some calibration, what worked today, what didn't, how can we improve, what does this particular group of trainees want to know more about. And as you know, we've done a needs assessment, so we have some good background on what the areas are that you feel are most important for your learning. So we really do want this to be suited to your class's needs and to be very interactive along the way in addressing any issues that we have and getting the content right for you. You'll see with the agenda that it's very substantive, very methodologically focused. And then a very important part of this is we hope to help you develop your own individual projects. You all submitted projects as part of the application process. We were very impressed with them, and we're very excited to see them develop. You'll work in small groups together with faculty mentors to develop those over the course of the week. Last couple slides here, basically principles of TIDIRH, and we're going to probably remind you of these when you come, but just so you come in with full knowledge, we expect you to be very actively engaged. We hope that you will set your devices aside and not be trying to be at the Institute and be at your home institution at the same time. It doesn't work, and you'll get the most out of this if you're fully in the room with us. You will work in your small groups and support each other along with the faculty mentors to develop your research and to develop those of your colleagues. So it's really important that we all participate actively in that. We have a core set of faculty, several of whom are on the phone today, as well as guest faculty and some funders. And so you have the opportunity to look at the agenda and contact folks that you would like to connect with, sit with them at a meal, ask for an appointment, and an opportunity to talk with them about any particular issues or ideas you have. So the whole idea here is to have really active networking. We also want you to develop a community of scholars, and so we'll develop hopefully collaborations with your colleagues in the training, and we'll be able to have a network of people that you can rely on to help you as you face struggles going forward. And then a major principle of this is also to provide lots of feedback. To prepare, we are going to ask you to develop a structured study abstract that will serve as the basis of the working groups and any discussions. Those are due July 10th. We're going to introduce ourselves via an elevator pitch. So we're going to ask groups of trainees to get up and do a 2-minute presentation on themselves and their work. This is really the elevator speech, and we really are going to time it. And at the end of 2 minutes, some kind of gong is going to sound, and you'll be done. So we would recommend that you think in advance about how you want to introduce yourself and time it so that we can keep the flow going. There are a lot of people, and we need to make sure we get through everybody. This will be a kickoff or a teaser to poster sessions, and I think you've gotten instructions on that. Your posters are due July 6th. And the idea there is you'll tease us with your elevator speech, and then we will come to your posters and learn more about your work and what your area of expertise is. We also offer you the opportunity to kick off discussions. You can take a look at the agenda, and we will ask people to basically develop an initial question or two to kick off the discussions in particular topic areas. So this will require you to hopefully take a look at the readings in advance and be prepared to ask questions. So that's the background. Before we go on to the content of today, let me stop and see, Joanne, are there any questions that have come in or chat? Or invite people to quickly put in any questions about the logistics or background or principles of the course.
I haven't received any questions yet. I'll be sure to raise them if we do. Oh, we have one already. We were asked if we can submit 2 posters if we have lots of D&I ideas. I think we'll deliberate on that and we'll get back to you. Unless, Karen, you have any thoughts immediately. So.
Nope, that sounds great.
Okay.
Okay. Thank you.
All right, great. I'm going to now hand things over to Dr. Ross Brownson.
Hey, Joanne, are you hearing me?
Yes, we can.
Hey, sometimes the technology is our friend. So, hi, everyone. I'm Ross Brownson. I work in St. Louis at Washington University in St. Louis. I split time between the Brown School and the medical school, and I've been involved with TIDIRH since the start, and I'm looking forward to meeting all of you here soon in Pasadena. So my theme on this is to talk briefly about some of the background around dissemination research and then a little bit about designing for dissemination, including how you think about that in your projects, some of the core constructs there, and how it might help inform our work in D&I research. So what are the things that happen when your issue has arrived? And we feel like for you and for all of us, the D&I issue has arrived. Well, one is you make your way into the popular press, so people out in the general public, including policymakers, see this as an issue. This is an article from Newsweek several years back now, I guess back about 6 or 7 years ago. Sharon Bagley talked about the valley of death, the gulf between the discoveries, what we've already learned, what we've paid for in our roughly $30 billion a year investment in health-related research, and then the long time lag that you'll hear a lot about at the Institute. This is one way to think about it. Another way is you have a cartoon. This one, to me, sort of summarizes why we're all coming to Pasadena. The latest research shows that we really should do something with all this research. I think all of you on the phone wouldn't have signed up for TIDIRH were it not for the idea that we don't do research just for discovering new knowledge, but we do it for applying new knowledge, improving the health and well-being of populations, including the delivery of clinical services, the delivery of public health services, the implementation of effective policy. So that's really kind of the backdrop of why we're showing up in the first place. The few brief objectives I'm going to cover in just about the next 15 minutes or so is to talk briefly of the differences, somewhat arbitrary, between dissemination research, research dissemination, and implementation research, which then we'll hear more about in a minute. Talk about theories a bit, what might be helpful, and then some principles and some backdrop for the idea of designing for dissemination, thinking up front about what we might do with the research while we're doing a D&I research project. This is a little arbitrary, and if you're a dissemination researcher, you might think of this differently than if you're an implementation researcher. But generally, dissemination is a broader spread. If you look at the third line down, the target, that's probably the biggest difference between dissemination and implementation, that dissemination hits a broader population, hitting a large population, a whole community. The big difference for implementation is it's setting specific. So if you're doing a project or a study within a school setting or within a work site population, that's probably an implementation study. If you're doing a mass media study or a study of state-level policymakers, that's probably more of a dissemination study. And so you see some distinctions there. If you think it's probably a little more structured in implementation, I would say there are more frameworks and models for implementation, and so that process is probably a little bit further along, probably because there's been a lot of studies done in clinical settings as well. Just a couple of definitions. dissemination is that active approach of spreading an evidence-based intervention. The common element in both of these is the idea of an evidence-based intervention. We know something that's worked, that's been tested in some form or another to scientifically make a difference in the case of TIDIRH, of changing health. If you were going to put research on the end of this and say dissemination research or implementation research, all you would add to that would be something like the study of the processes and the factors that contribute to. And then, of course, the underlying issue here is evidence-based intervention. One of the key issues is always sort of what does evidence-based mean? What does it take to be sort of marked as an evidence-based intervention? And that's a little bit in the eye of the beholder, but we'll talk quite a bit about that at TIDIRH, and that's also something in your own particular area where you might want to talk with and consult with the faculty while you're there. There are a few important properties to keep in mind when it comes to the concept of dissemination. And here's a list of 6. So dissemination is not a spontaneous process. It doesn't just naturally happen. I think in the early phases of our trying to apply research in public health and clinical settings, we thought that magically if we have a new guideline or evidence-based intervention, it's magically going to be adopted. And we now know from many studies that it doesn't magically just happen. We also know that passive dissemination, just putting something out there, listing it, will maybe pick up what Ev Rogers called the early adopters, but for the large group, for the vast majority of people, that's not going to be effective, that it takes some more active strategies. The third one relates to the idea of ecologic frameworks, that health and well-being is determined by multiple levels, all the way from the individual level, someone's gender or age or genetic makeup, all the way up to the policy level, the broader community factors that influence health, and all the things along the way. And so we know that the most effective public health and clinical interventions address multi-level approaches. We know it's very important to involve our partners, our stakeholders in the research and the evaluation process, and that has a beneficial impact on dissemination. You'll hear quite a lot about theory and frameworks while we're there together at TIDIRH, and that's very important. And then we also know that the process of dissemination and implementation needs to be linked with and tailored to the characteristics of a particular audience. So if there's a new immigrant population, maybe there's a set of cultural factors that might affect the process of adoption or dissemination of an evidence-based practice. One of the questions we always run into is it research dissemination or dissemination research? And of course, the answer is yes, or it depends. You know, you're going to be there mostly talking about doing research. Many agencies fund the dissemination of research. So if something is done, maybe an agency like the Centers for Disease Control or AHRQ might fund the dissemination of that research, but you'll be conducting how do we more effectively spread the effective interventions. And so federal agencies do both. You're going to be together learning about research dissemination. When we talk a minute about designing for dissemination, that really fits into both of these buckets. And so now, and Joanne, I hand this back to you now, right?
Yes, that's correct.
Okay, so let me just set this up. What we're going to do now is ask you to help us with a little audience response on 2 questions. So if you'll just read the question here, the methods you use to disseminate your research findings, whatever kind of research you do, which one do you think generally has the most impact on your career trajectory? So, Joanne, if you'll go ahead and do this one, and you'll fill in the blank here, everyone. Everyone can see the clicker over at the right.
I'll give people just a few more moments.
Yep. Give you just a few more seconds here. You can see the process.
Looks like we only have 2 folks that are thinking about it. All right, we'll go ahead and close.
Yep. Okay, see results.
And everyone should be able to see the results.
Okay. We see by far 17 out of 24 picked academic journals as the number one. We've got a few that picked policy briefs, 4, and a few that picked face-to-face meetings and media interviews, okay? So there's the clear winner is the academic journals, okay? Now let's go on to the next one. So this one is of the methods you use to disseminate your research findings, which one do you think generally has the most impact on public health or medical practice or policy, depending on if you work more in public health or more in clinical practice. So if you'll do the same thing again, pick the one out of this list. And we'll give you a few minutes again. You have it coming in. We're going to talk a little bit more about this second one than we are about the first one. Just a minute here. I'm going to give them just about another 10 or 15 seconds, Joanne.
All right. Looks like we have most everyone in.
Wrap it up?
Yep.
Okay, now, well, I can tell you you're not a representative audience here, so let me see if we can head over. So you've got 42%, followed by, I'll just rank order these. 1, 4. Okay, so let's go on. And Joanne, can you hand it back to me? Yeah, here we go. Okay, so let me show you kind of a parallel bit of data. So we ask similar questions, especially this second question about the most effective way of impacting to a set of state and local public health practitioners, and we found out how they most likely find out about the latest research findings. And you see the listing there. We didn't give you the exact listing here about professional associations, but the first and second here probably are very much the same for them. And they listed journals as kind of a distant fourth on their list, and really roughly 30% of them even read journal articles. But then another study we did with a group of about 250 state-of-the-art public health researchers who are obviously a little different than you are on the phone. Here's the listing of how they perceive they most effectively reach practitioners. And you can see they rank journal articles first, all the way down to press releases at last. The face-to-face meeting, which you ranked first, they ranked second. So they flipped that one. And maybe because I set this up in a certain way, you already thought of the answer in a different way. But obviously the mismatch here in the tale of the two worlds is how we think we're reaching practitioners and our partners is very different than how they would like to be reached. And I think that's a really important thing to keep in mind in your own work as we go forward, no matter how it is that you define this idea of a practitioner, whether it's public health or a clinical practitioner or a policy audience or a health promotion director of a workspace, okay? So that's a little backdrop there. I'll go on here and talk a little bit about the theories and frameworks that are very important to your work, and as I said, will enhance our ability to do good dissemination. There's an article that we'll share with you that Rachel Tabak in our group led that identified over 100 D&I-related models. Many of them focused only on practitioners, so they weren't quite appropriate for research, and boiled it down to 61 models that we thought were appropriate for D&I research Of these, 11 are what we call D-only, dissemination-only models. And then we looked at a number of variables related to construct flexibility. How flexible is the model? The SEF is the social ecologic framework, and the D versus I is dissemination versus implementation. And so we will have this article for you. We'll talk more about it at the meeting, but it's a nice setup to help you in thinking about how you choose the appropriate framework for your work. When you do a research study, you think about if you have a model or framework, was it fully developed through your proposal? When you finish, will you have advanced the theory, the framework? Will you advance the field of dissemination research? And then maybe think about something from outside the usual health realm as well, okay? And the last little bit kind of circles back to the idea of designing for dissemination. A study we did of about 266 U.S.-based researchers from a combination of universities, from the NIH, and from the CDC. We asked them about how they put their research findings out there, especially when they're trying to reach non-research audiences. The first question is how they thought they did. We're fairly self-critical. Only 6% of us said we do an excellent job at this, so you can see vast amount of room for improvement. And you see if you kind of link together poor and adequate, it's basically 2/3 of the group says we're only doing an adequate or even a poor job of building this. And so this just takes us to the idea of designing for dissemination, thinking about an active process that helps us put the interventions out there more effectively and developed in ways that better fit people's needs, their assets, and the time frames. And so this summary is this article we had in the American Journal of Public Health a few years ago. We asked people about how they spend their time. Most spend very little time on dissemination. Encouraging, about half have a person to help them with it. About a third, this number could improve, about a third always involve stakeholders, and roughly only 20% use a theory or framework. So a lot of room for improvement there. People who did better in dissemination were those affiliated with one of the CDC-funded prevention research centers or who had practice experience. And generally, we had lower values for NIH researchers, which is somewhat expected because NIH researchers are not necessarily focused all the time on doing dissemination, especially if they're intramural researchers at NIH. What might help? What might help us improve this D4D, the designing for dissemination process? Well, 3 broad buckets: systems changes, shifting our incentives, our researcher incentives, developing new tools, so new websites, ways to get the word out there, maybe using social media or other ways of reaching our target audiences. Engaging our stakeholders better, early and often. Only 17% are even using a theory or framework, so making much better use of theory and frameworks. Identifying better ways of delivering the message. That includes who delivers the message, the timing of the delivery, how it's delivered, and then the products, using some of you in your little survey, 17% said you do policy briefs. Well, doing policy briefs is a creative way of taking what is often in a journal article and summarizing it in a user-friendly way. Okay, so that's just a little snippet. If you want to know more about that, I'll be glad to speak more with you when I see you soon in Pasadena. And so my final bit of take-home points is that there's a close nexus, an important nexus, between dissemination research and then research dissemination. So learning about what's effective and then putting it out there and spreading it in an effective way to reach the audiences we want to work with. There are many theories, many overlapping constructs, and these will improve our research and our ability to design for dissemination. We need to plan early. And then generally I would say the messier the research topic, the harder it is to control, the lesser there is of really good dissemination research, which presents really great opportunities for you to be able to do more of this kind of research. And I think this, this is going off script a little bit, but I think this week, as Karen noted, is really a gift for you and for all of us to be together for a week with really some of the leading scholars in the world, both in the faculty and among your peers. So just really make the most of it, commit to learning everything you can from the sessions, connect and network with the faculty, and then connect and network with the peers, and go into the week thinking big and really how you can use this as as sort of a catalyst and a launching board to really move your D&I research to the next level. So I think it's really a great opportunity, and I just encourage you to really make the most of the week that we'll have together. So Joanne, that's it for my part. I'll hand it back over to you.
Great, thank you so much, Ross. I'm going to now hand things over to Dr. Amy Kilborn, who's going to talk to us a little bit about implementation science.
Great. Thanks. I hope everyone can hear me. Good. So I'm going to really just, thanks Ross so much for that really great introduction. I'm going to continue the conversation and talk a little bit about implementation science and give a pretty, I would say, a very thumbnail sketch overview of the implementation science from a theory perspective, but also just from a perspective of the research. So basically, you know, one of the things that often really, I think, perplexes us in the world of clinical research and also health services research is that we often feel like we work so hard, like in Indiana Jones and Raiders of the Lost Ark, to actually get something or discover something only to have it really sort of shelved away and not really be implemented in ways that could be, you know, useful to public health. And so I think that it's going to be especially important to think about the ways implementation science can really impact public health in general, and really ways in which we can basically use implementation theory to develop strategies to better translate that research finding into practice. And so in doing so, you know, we really have to think about it from the perspective that healthcare in the United States and also elsewhere is changing. I think one of the biggest changes is really the growth of technology and the growth of big data, particularly with the information sharing happening between the patients and providers really becoming more fluid. That's also really a big part of e-health and m-health tools and the promulgation of those technologies. And then in addition to that, with healthcare reform, I think things are becoming organized, you know, particularly now with the Supreme Court ruling, we'll be seeing a greater focus on the organization of the healthcare exchanges and Medicaid expansion. And then finally, there's really been this push to, you know, think about the U.S. healthcare from the lenses of what the Institute of Medicine has called the learning healthcare system, which is really, if you think about the notion that it's not just having healthcare react to every time a patient comes in for care, but to be proactive and to use the data to show how care can be improved, and then also to use those data to optimize the care in terms of continuity, and in doing so, really doing it in a way that is less about being bureaucratic and more about being sort of empowering the frontline providers, and that's really where implementation science can really weigh in there. So implementation has really, I think, traditionally been at the sort of tail end of the 3 T's roadmap. You know, you have the efficacy and effectiveness studies, and the implementation is really how, or what the learning healthcare system is talking about. You know, how do we actually get care to improve? You know, I think part of the training, we'll also talk about the role of implementation earlier in this pipeline as well, but that's sort of been a traditional focus. The long road to the learning healthcare systems and why we need implementation is the fact that the research that we conduct often takes too long to get adopted. Oftentimes the research we conduct may not be aligned to address critical healthcare problems. Providers often lack the tools or technical assistance to implement effective treatments, so it's not enough just to give them a publication and say, hey, we found this great program, go implement it. It takes more than that. Large programs, you know, policies across the country are being rolled out really without adequate planning to maximize effectiveness in learning. And then finally, you also have the, you know, the notion that care is varying considerably across different settings and environments. So implementation, I think, has traditionally been thought of as a linear process. This is a diagram of the first generation implementation pipeline that was published by the Quality Enhancement Research Initiative, which really showed this idea that you start with a research topic and you move forward and you do these small to larger scale studies. Oftentimes, I mean, in this day and age, I mean, we can't often really wait for the findings to really be tested in numerous clinical trials before implementation. So I think beyond the pipeline, there are several instances where we often go back and forth and essentially really, you know, on the one hand, study some key areas because we've done clinical research, like in, you know, the observation that there's increased lung cancer in smokers, for example. And the observational studies really go back to more preclinical studies, which often can, lead to more population-based epidemiology studies and often back to doing intervention trials. So sometimes it's more of a zigzag rather than a pipeline in terms of how research progresses. And not surprisingly, I think implementation science should be really at that stage, at every stage in terms of basically being, present there. So the QUERI second generation implementation pipeline really talks about what happens, once you have clinical or population data. Now, regardless if it's from a randomized controlled trial or just observational studies, there are really several barriers to where it gets implemented. And so the focus has mainly been on, essentially, I would say 3 key areas. And, I think one of the key areas is that, if you're asking providers to do yet one more intervention or clinical practice, you might get a lot of resistance, especially from frontline providers who are asked to do yet one more test or treatment. In addition, oftentimes many randomized controlled trials are, what Ross had talked about, the design for implementation or dissemination, many of these, essentially these studies are being conducted in tightly controlled settings and not really in real-world populations, in terms of clinical samples that don't really match up to where, the diversity of the population. Another issue is, and especially we see this in national or even highly nationalized programs, is that we may have a lot of neat things that we want to implement or in terms of evidence-based practices, but it's simply not a priority given all the other priorities that are going on in healthcare. And that's also been a very important issue as well. So those are some of the gaps, or what I would say the barriers to improved health, improved public health, and how implementation can address it. Really, in ways in which you can do it is, I think in, again, 3 main areas. On top, really this idea of designing provider-focused initiatives, ways in which you can really support frontline providers in the implementation, either through organizational change or financial incentives or other types of strategies, or designing actually the interventions themselves so that they can fit with the needs and the constraints of the real-world populations to begin with. Then finally, there's also been a push in a policy level of doing randomized program evaluations at the policy level, which really seek to basically better understand through experimental design policies or dissemination techniques that could be better used to promote the uptake of effective programs. So implementation science, there's sort of the definition that we often use is a scientific study of methods to promote the systematic uptake of research findings into routine practice and in ways of improving the quality and effectiveness of health services. And in terms of synonyms, I mean, you often hear the term knowledge translation, especially from our compatriots up in Canada, and also the term technology transfer is often used in a way to describe similar things as well. I think it's been mentioned before, we have implementation science, as Ross mentioned, journal publishing is insufficient. And again, I think the idea that you really want to develop those relationships with providers to really convince them to, enhance the uptake of a new evidence-based practice. And I think also because of the way healthcare is changing, there really needs to be a set of implementation science strategies that really deal with both the bottom-up and top-down ways in which we can promote the uptake of evidence-based practices. So it really involves managing partnerships. One of the things we often talk about in our circles is the idea that we're in implementation science, it's not only about publish or perish in academia, but I think if you're really wanting to make a difference, it's also partnering or partner or perish. And so there's really this balance that you need to consider about, how long do you wait until you have the right or the perfect evidence-based practice before you implement, especially when your operations partners, and those can be individuals like in the community who need, something to help improve the health of a population or a health plan. At some point there needs to be a balance between the need to wait for the evidence versus doing something that might be good enough and time-sensitive for time-sensitive needs. So implementation theory there was a really great article by Carl May that really describes, I think really the big picture of implementation theory, and it basically defined it as a deliberately initiated process in which agents, if you think about agents as providers, intend to bring into operation new or modified practices or evidence-based practices that are institutionally sanctioned and are performed by themselves and other agents. And so the key terms here are process. That's never really the, an end-all and be-all. It's often a continuing process of implementing research into practice. And the agents are really the important key players here, and to make sure that they are essentially supported in that. And that's usually because something that's being supported isn't institutionally sanctioned, either through the use of evidence-based guidelines or leadership support, or both, ideally. And then also because it's this notion of really, again, it's being a process. So the general theory of implementation that Carl May published really looked at some three key areas. The capacity, which is, if you think about it, the resources of an agency or an institution to be able to provide support for agents to implement evidence into practice. The capability, that's the actual evidence itself in terms of what the intervention is. And finally, the potential, what is sort of the resources available to the providers themselves. And that really gets into some of the literature around self-efficacy at the provider level, as much as we often talk about it at the consumer level. And so, all three of these factors really contribute to the process by which something gets implemented. What influences implementation is a multidimensional process, and some of the best, frameworks to actually describe what influences implementation are the Consolidated Framework for Implementation Research by Laura Dan Schroeder and others who have worked in this area have done some amazing work on really operationalizing these types of frameworks. But it really gets down to the idea that you have system or organizational resources or factors of the external environment. You have the program characteristics themselves and the evidence-based practices, and then also the provider characteristics in terms of how it works, and then how they come together to really basically work in day-to-day operations. So applying this type of theory, I think is really the next step is to think about choosing what implementation frameworks you would work with. And I think that one of the best quotes from Ann Sales is that theories inform the frameworks that provide the undergirding of infrastructure, much like the frame of a house. And so they help you both explain how implementation activities will affect a desired change and what implementation strategies should be planned, or what has been called a process. Some key examples of implementation frameworks, I mentioned the CFR earlier. There's also the Theoretical Domains Framework and the Green Law Implementation Process Model. Those are more the explanatory frameworks that really teach you what are some of the factors that contribute to implementation. If you're looking for frameworks to help you either sort of better implement or measure the process of implementation, the REAIM framework is definitely one that we often use to basically describe, to what extent a intervention is being promulgated in real-world practice. In addition, the evidence-based quality improvement, blended facilitation, the replicating effective programs, and getting to outcomes frameworks are all really directed or applied types of frameworks that are used to basically, in a highly specified way, to help implement research findings into practice. And to give you some examples, it's really, I think, key to think about how these different frameworks inform, I think, what is one of the more important areas that implementation science contributes to, which is the development of implementation strategies, which are highly specified systematic processes we use to implement treatments or practices, often at the clinic or provider level, into usual care settings. They're designed to address barriers and facilitators to adoption, buy-in and dealing with buy-in from providers and organizations. So that idea of, sort of what is it in, what's in it for the frontline provider who you're trying to convince to adopt a new evidence-based practice, and what should be tested across effective practices or programs. And in doing so, this is a very scientific but nonetheless sort of heuristic schema of the types of implementation strategies and some examples that are currently being tested as ways of enhancing the uptake of an evidence-based practice or effective program. And they often vary based on the cost of the strategies themselves, how much it costs to actually implement something versus the need of a site or a community in terms of how much support they need to implement an evidence-based practice. So if you think about in the bottom left corner, the training technical support, some of the models that tend to focus more on training and fidelity, such as replicating effective programs, often have a lot of front-end costs from the researchers, but the cost to the actual sites may be relatively low because it's usually involving training. If you need additional support where there might be need there might be a need for more provider mentoring or coaching about how to actually implement an evidence-based practice into routine care. Then models such as facilitation or getting to outcomes can be beneficial there. And in some of the great work by Ken Wells and Loretta Jones in terms of a community engagement implementation strategy, that also includes, again, some more time-intensive, but nonetheless, relatively, I think, very effective ways in terms of more effectively promoting the uptake of evidence-based practices into community-based settings. And then finally, if you really want to do the deep dive where you're really seeing some organizations or sites that are in need of more of a sort of a cultural change, there's really these health systems engineering or lean practices, many of which often kind of sort of backflow between the notions of learning collaboratives and other types of work that others have studied to some extent, with a lot of different literature out there about their relative effectiveness and so forth, although the study designs tend to be a little bit different from the quality improvement literature. But those are just, again, some of the key examples of what's out there, and really at this point, we're really not at a stage where we have an arsenal of implementation strategies for different sites and for different stages of adoption at different places, but it's certainly something that many investigators in the world are really striving towards. So one example of applying an implementation framework as an implementation strategy is the Replicating Effective Programs framework, which was developed by the Centers of Disease Control to rapidly translate HIV prevention interventions into community-based settings. Enhanced REP, which was recently developed, includes additional provider coaching or facilitation, which is the idea of working on the provider's interpersonal skills to help better implement research into practice from a sort of interpersonal standpoint. That's been also developed, and that's really more focused on the notion of enhancing provider self-efficacy. And so this type of model is really, again, very much heavy on the provider training and the provider coaching, and also the focus on the fidelity of the treatment itself. And I think that in many respects, in many settings, has been shown to be effective in terms of improving the uptake of evidence-based practices. So in terms of ways in which these types of implementation strategies can be tested, there was an article by Jeff Curran and colleagues on different types of hybrid effectiveness implementation designs. These are ideal types of designs to test different implementation strategies. They often address the limits of the stepwise research, meaning that you're not waiting until the research evidence is finally there until you finally implement it. There's ways in which you can do a combined test of both the effectiveness of an intervention and its implementation strategy that you plan to use to enhance its uptake. So it's really a way of blending both of those in a way that promotes the external validity. Types of hybrid designs include the hybrid type 1s, which really are the standard effectiveness studies where the focus is more on testing a clinical intervention where you gather its information on how it's being implemented, usually by existing providers. A type 3 hybrid design is basically focused on testing different implementation strategies where all the sites get the same clinical intervention, but there's a gathering of information on the outcomes at the patient level. The hybrid type 2s are the more complex designs because you're essentially blending an intervention that's both a clinical intervention for patients and an implementation strategy for providers. And in those situations, it's often, complicated, but sometimes often needs to be that way because you're essentially trying to both implement and test the effectiveness of an intervention, especially for situations where there is a time-sensitive opportunity from a leader or operations partner or health plan saying, we got to implement this now. We cannot wait for the clinical effectiveness studies to come out. How can we both measure both its effectiveness and its implementation? And the key there is to be able to basically collect information on both patient outcomes as well as the implementation of those. So in going ahead, there's the table here just describes the different types of hybrid effectiveness implementation designs and what key questions is it really, I think, best suited for. So essentially type 1s are really the effectiveness type of designs, and type 3s, for example, really look at different implementation strategies. So this is an example of a type 3 hybrid where REP was compared to standard dissemination of a toolkit for the uptake of HIV prevention interventions and AIDS services organizations. So after 12 months, you see this sort of a gradual shift between sites that got manual only versus manual plus training and manual plus training plus technical assistance. And this was conducted over 15 years ago by Jeff Kelly at the Center for AIDS Intervention Research. So take-home points, I think the most crucial piece is that nothing is more practical than a good theory. That's something we often talk about a lot in my background in public health. Secondly, it's really important that as designing or even thinking about a career in implementation science, it's going to be equally important to partner and work closely with operations partners, whether it be a health plan, the VA, whether it be with community-based practices, because some of the best ideas for implementation studies come from them. You understand what your stakeholders need. You get a lay of the land. You understand the barriers and facilitators to translation. And also, it's complicated, but oftentimes you probably need to expect to jump on moving trains where you need to basically be prepared to design a study when the actual program or organization is already taking off and wanting to implement something. And so that is going to be key. And implementation science is really about that deep dive about how it works as opposed to, or in addition to what works. And how it works, it really needs to also be focused on studies that go beyond barriers and facilitators, but also looking at the process of implementation. And in doing so, it's going to be important to mix both top-down and bottom-up efforts to implement and to think about specific strategies that could be informed by theory, tested in practice, and then really rigorously evaluated through randomized trials such as type 3 hybrids to really find sort of an arsenal of strategies that can be used to implement research findings into practice and ultimately improve the public health population. So I think I'll stop there. I think I'm out of time, so any questions?
Okay, great. Thank you so much, Dr. Kilborn. So just a reminder, you can submit any questions by using the chat panel to the right-hand side of your screen. We will be sharing the slides from today, and we'll also be posting the archived recording of this webinar on the TIDIRH website as well, and we'll notify everyone once that's done. So we had a question, I think it was for Dr. Kilborn from Dr. Halwindi. How does research dissemination differ from research uptake?
So great question, and I think, Ross, it would be good to get your thoughts as well. So I often think of research dissemination as a more passive distribution of knowledge about the research. Research uptake is the actual measurement about whether that knowledge is being used in clinical practice.
Yeah, I think I would agree, and I think research uptake is probably something that we more often can study in a research sort of setting, and research dissemination is just sort of a very heterogeneous way of spreading a new discovery or spreading the importance of an evidence-based intervention, but there's definitely a lot of overlap between the terms. One thing that you'll find useful, we've done several glossaries. Borshika Rabin has helped us develop a couple of those, so just kind of getting the terminology straight and figuring out what terminology works best for you and the work you're doing is also very important for our field.
Okay, thank you. One of the other questions was whether the poster presentation was intended to feature our profiles or our intended research. I don't know, Cindy, Karen, if you wanted to kind of give more of the intent for it. It'll be kind of a bit of both.
Yeah, Cindy, do you want to add to that, or would you like me to take it?
Sorry, could you repeat that?
Whether the poster presentation was intended to feature our more personal profiles or profiles of the intended research.
It's the research, I'm sorry.
Yeah.
Yeah.
Yeah, so it's intended to be a nice layout of what you're planning, at least at this point, thinking about a specific dissemination or implementation research project.
Understanding that hopefully will be changed and expanded upon during the week.
Right.
We have Janet Gell, who's on the phone. She was interested in learning more about the hybrid designs. the rationale and study of them prior to the meeting. So I was asking if there were any other research groups doing work in this area or any articles that might be recommended.
Sure. So this is Amy. I would definitely read the one by Curran that I referenced in the slides. That really provides a great primer on the hybrid designs. And in addition, I think some of the main groups that have published on the hybrid designs have been the VA investigators in the Quality Enhancement Research Initiative. Start with that 2012 article, and I'm more than happy to provide some references at the TIDIRH training as well.
Great, thank you. Let's see. We have a question from Rachel Shelton. Should we present research as part of the poster presentation that is informing the work we will be developing while there?
I'm assuming that the, oh, go ahead.
Sorry, go ahead, Karen.
I was just going to say, I think it's a question around should we be presenting your own pilot work that leads to that or the larger body of science. I think what we're really interested in is your own work and where you're taking that. So you could provide a small amount of background on, the literature, but I think what we really want to know is what you've done, what your foundation is, and where you're going. Others, faculty may want to add to that, but that would be my take.
Yeah, it's David Chambers. I would agree. I would just say that, as people prepare different posters for conferences, they'll often have that background section that might allude to what sets up the reason for their study that they're proposing.
And understanding that part of the training you're going to be learning different components, so that you may have some questions that you hope to answer during the training that can be reflected in your poster.
Right.
Great, thank you. Any other questions? We'll wait a couple more moments. I know we're coming up towards 3 o'clock now, just in case people are typing some questions.
While we're waiting for folks to add their last questions, and this is Karen, I just thought I would thank both Ross and Amy for their great presentations. It's a great kickoff to the quality of work that you're going to see in the Institute. I think this is going to be such a wonderful and deep immersion for you, and great opportunity to spend time with each other and with some of the leading scientists in the field. So we're really excited about this, and it feels very real now that we've had this kickoff webinar. So thank you, both Ross and Amy, for your presentations today.
Okay, I have no other questions.
Okay. So let's thank everybody for joining. We're really pleased, and thank you to the faculty who also joined to get a sense of what our trainees were exposed to today. And we're going to have a lot of fun together in about a month, so we're really looking forward to it. Get some rest beforehand. It's going to be intense, and it's going to be a great experience. So thanks, everybody.